Fantastic time on Thursday. So thanks to Cyclops. And as is usual, you see Dr. Srinivas is running even on the road to serve us well. I'll be talking on psychological factors in dizziness. As you know, the definition of vertigo, as an undergraduate also we have learned that there are many definitions. Similarly, in psychological factors, the psychiatric factors, the functional dizziness and all sorts of dizziness, you will all get fumbled. So I have kept it at that. But the picture, what is the significance of this picture? Can anyone tell me? Which came first? Yes, that was in the school time, whether the egg came first or the hen. So that is there even in the psychological factors in dizziness. Whether the patient suffers from psychological trauma due to the dizziness or it's the reverse way. One of a very prominent ENT surgeons who was a psychiatrist as well, Clark, he said that the patient with chronic dizziness should never be labeled with psychogenic dizziness because chronic does not mean psychogenic. Sometimes till the time in face or sinus surgery, we are labeling allergy hai. So that is something in vertigo also, that those we can't define well. Chronic means that the healthcare providers has not been successful in diagnosis the correct way. So that is should not be the case with psychological factors. Well, a lot has been said about all the peripheral lesions and this, but in psychological factors you find that the mainstay of diagnosis or perhaps the only tool is the history. You have seen psychiatrists taking long time to diagnose of dizziness. So is omission the best way? By ruling out peripheral lesions, by ruling out certain central lesions, is it the way to diagnose the psychological factors or the dizziness? No. Because this, we'll extrapolate the hen and the egg. There is a psychosomatic model, a primary psychiatric disturbance causing dizziness. That is a psychiatric cause is the chicken which causes the dizziness egg. The commonest example we all come across is the hyperventilation syndrome. Then comes the somato-psychic model. A primary inner ear disturbance causes anxiety. Sometimes if it lasts long, it will cause depression, which produces more dizziness. So that is another model for it. Now most of the time, peripheral vestibular lesions we can diagnose with much more precision now that we have got many. But when there is non-localized vertigo, we are not able to, we label it as central or something like that. In that case also we can have two cases, which acute, which we present in the emergency rooms. In chronic case, we ENT people or the neurophysicians or even the psychiatrists, they go in chronic cases. I'll not elaborate because there is a little bit of time constraint. Madam is looking at me for her lecture that I will not be eating in her time. Psychological syndromes that can cause dizziness. Psychogenic dizziness or vertigo consist of a sense of motion and all that. But basically, there are three types of psychological factors that you come across. One is the anxiety. That is, in acute cases, patient is very anxious. The second is the depression, long-standing dizziness. And third is the panic syndrome. You will be surprised. I had a case wherein a lady, ages 70 plus, she had never got any sickness. She came to me with episodes of vertigo in last 7 days. So I asked her routine history and took some test and all that. Then I decided to have a VNG. The moment I placed that camera and also this figure, she was absolutely in disaster. She said, I can't just tolerate it, and she was in a panic syndrome. I had to leave the test. Even after half an hour of making her understand that we could diagnose something concrete and I could treat you in a better way, she just was not ready. I had to let her go and say, you come after 5-7 days. So that is sort of a panic syndrome that we can come across in our clinic. Most depression is reactive. कंटाल गए, कितने डॉक्टर के पास गए लेकिन कुछ फर्क नहीं पड़ता है. They were depressed. Major exception occurs when dizziness symptoms are used by depressed patients who are attempting to make a contact with the medical system, hoping, this is of course in foreign countries, but this is coming to our place also, that hoping to obtain a treatment without being labeled as having socially stigmatizing. किसी को बोलते हैं psychiatric, आप लोग vertigo clinics में setup में psychiatrist is always there. And when we advise them that you visit a psychiatrist, they would flatly say no, because they won't accept that they are having a psychiatric disorder. Similarly, malingering, to obtain compensation, to obtain a certificate that they are ill for the job, on the jobs. So malingering also we have to rule out. This is a type of a psychological disorder. Psychological syndromes that may be a consequence of vertigo. That I said that in acute cases it is the anxiety, whereas in chronic cases it is depression. And we have to distinguish the unreasonable. Sometimes the patients are very unreasonable with us. All doctors must have come across this, that they are more anxious than anxious. In the sense that they are more demanding, certain patients. Vertigo, they will exaggerate their symptoms. So we have to be very cautious about this. Then it's very funny how an ENT surgeon, how a neurophysician, how a psychiatrist will deal with the same patient in a different way. So if it comes to a psychiatrist, the psychiatrist would elaborate out on different, that I'll come in the next slide. But when it comes to the ENT people, it's just like diagnosis of exclusion. Because Meniere's nahi hai, vestibular neuritis, this and that. And then we will say that, okay, it looks like a psychiatric, but that's not the real case. So diagnosis of exclusion is a wastebasket syndrome. Everything that we can't diagnose, it goes to the wastebasket. Then what we see many of times is, doctor would tell the patient, look, I have been doing all the tests, laboratories, imaging, VNGs, but I don't know why you are dizzy. So patient also would feel that he would visit another doctor. That doctor also will tell the same story. So everybody is in a dizzy, sort of. And these are the verbs, new entities. This is coming from the psychiatrist domain. Phobic postural vertigo, chronic subjective dizziness, is also known now as P3D, those who attended the lectures in the hall A. Then post-traumatic stress syndrome, that many of us might have seen those patients, who accident prone or who was accident in the past. They feel psychogenic vertigo. They say, I'm feeling dizzy, I'm still not stable. Basically, it is all psychological factor rather than any lesions in the periphery or in the center. Then, of course, agoraphobia and acrophobia. These words, open spaces. Patient doesn't like to go in the open spaces. And some patients are afraid of looking down, height. Those type of also, they feel dizzy. So all these things all come under the psychological factors, and doctors in a busy OPD need to rule out. It's not that everybody who comes here, kaan mein sujan hai aur jao. Most of the patients are, at least at the general physician level, I have seen, chakkar hai, write down Cinarizine, Betahistine, and then they fumble. I had a case, one night I received a call from a lady about 50 plus. Now, she has a very typical history, that whenever there is a traumatic experience she had in her family, she would get giddiness. So some general doctor had given her Cinarizine. So she said that whenever I take Cinarizine, I feel very fine. Then after 2-3 months, it so happened that Cinarizine didn't work. So she jumped to beta-histine. Then she tried another. She went to United States and they called from there, look, I said, these are all as good as placebo for you. What you need, you contact your psychiatrist. It was then that she told me that, yes, I had a psychiatric consultation some 10 years back. So she had a background of psychiatric illness actually. So these things should be taken into consideration. Investigations. Whenever there is psychology, it's only for exclusion. We have to investigate for patient satisfaction because these days patients believe more in machines than in doctors. It is to rule out other causes and of course to pay your EMIs for whatever machines that you have bought. I'm not talking about government hospitals, they don't bother, that's why. So what's the management of these patients? First you try with the basics, alprazolam, escitalopram, but the most important thing is counseling. You have to allay the fears of the patient, that is most important. You have to give some time. And I have found that if you tell them, look, that you are going to go fine, they feel bad. Otherwise, you have to refer them to a psychiatrist. This is something spiritual thing that I have kept the slide. That whatever you have learned here in the yesterday and today morning since 8:30 is related to the body. The body perceives and its object. You can diagnose most of the thing. But whenever the psychiatric angle you look at it, it's the mind that is at work. And there are no investigations for that. Psychiatrists, they take history and all that. But there are certain fluoro assays and all that are being done in the West, but still it is mind which feels it. So headaches, dizziness, all those things, patient tells and you just wonder what is that. That is where that sentence comes in, that I don't know why you are feeling dizzy. So body, mind and intellect, they work very differently and you have to manage all these things as a doctor, then only you can treat the patients for the vertigo. Thank you.